All right, so when it's time to reassess our patient, and this is likely being done on our way to the hospital, then we're going to fall back to if the patient is stable, then we're going to reassess every 15 minutes. And if they're unstable, we want to reassess about every 5 minutes. We also want to consider the need for ALS, whether we're waiting on scene for them or whether we're meeting up with them en route to the hospital if we haven't already. And when we're doing that reassessment, we're reassessing the chief complaint, we're reassessing vital signs, we're reassessing interventions, and we're seeing, has anything changed? Has there been any changes that require a new course of treatment, or how do we need to progress from here? Most medical emergencies require a level of treatment beyond that available in the pre-hospital setting. So that means that even at the EMT level, there's some stuff that we can do, but not everything. And it's the same way for ALS providers. There's some things that they can do and some things they can't. For long-term medical issues like ongoing hypertension, ongoing high blood sugar, people who need antibiotics, those types of things, they need to be managed in a hospital on a long-term basis and don't really require a whole lot of emergency treatment. We do want to consider our scene time. This may be a little longer for medical patients than for trauma. Again, if it's a life-threatening situation, we still want to be off the scene within 10 minutes and provide that rapid transport. But if it's not, then we probably spend a little bit more time on scene here with the patients, maybe 15 or 20 minutes as opposed to the 10 that we try to limit ourselves to with trauma. If this is a non-life-threatening situation, which most of our transports will be, then we are going to provide non-emergency transport, so no lights and sirens. If it is a life-threatening condition, and so a few examples of medical life-threatening conditions where we would use lights and sirens would be someone who is actively having a stroke and someone who is actively having a heart attack. Those are really two examples of times when time is of the essence, time is tissue, and so we want to get there as quickly as possible. We do have the option between ground and air transport. Now, this is going to be a big factor in where do you live and what type of resources do you have available to you. Right here in the Johnston County area, we have a lot of resources available to us by ground. So we have trauma centers, we have cardiac centers, we have stroke-capable facilities available to us by ground. Even our burn center is available by ground and accessible by ground in a reasonable amount of time. Now, our neighboring counties, even here in North Carolina, looking out towards the coast and up towards the mountains, they don't have those same abilities to access these facilities as quickly. Or even sometimes at all. And so air transport might be more utilized in those areas than it is in the central region of North Carolina here. So you want to know what your policies are for the agency you're working for and what type of resources do you have available. When you're selecting the destination to transport your patient to, it's really, again, going to be dependent on what their complaint is and the severity of it. If you have someone who is just having a generalized medical complaint, then local transport is often okay. If you have someone who is having a stroke, a heart attack, major trauma, burns, those things need to go to specialized facilities. And so you want to know what type of specialty facility do you have available to you in your area, and does this patient meet the requirements to go there? But then we also want to keep the patient's choice into consideration as well. We can't twist anybody's arm. If we recommend going somewhere and they refuse that, then we can fill out the refusal for it. We can contact medical control if we need to. But ultimately, we want to get them to the best definitive care that we can. So that's going to depend on what is going on and what type of ultimate treatment are they going to need. Looking at infectious disease really quickly, we're going to approach these patients that like any other medical patient, but we do want to take some additional standard precautions, asking them about if they've traveled or come into contact with someone who has traveled, especially outside of the United States. If it's something that could be contagious, we're trying to focus on any life-threatening conditions, identifying the primary assessment again before we move on with the remainder of the assessment. We always want to look and see if there's anything that needs to be addressed with the A, B's, and the C, so airway, breathing, and circulation. We want to be empathetic to the situation and make sure that we're putting ourselves in that patient's shoes and treating them the way we want to be treated. We also want to place the patient in a position of comfort whenever possible and keep them warm, and that goes for most every patient that we come into contact with, especially medical patients where you don't have that concern of spinal immobilization. Position of comfort is the best way. Now, ironically, we happen to hit this chapter right in the middle of a pandemic. So we're looking here at epidemic and pandemic considerations. So an epidemic is where new cases of a disease in a human population substantially exceed what is expected. And then the pandemic is where that is happening on a global scale. And so right now with coronavirus or COVID-19, that's what we are currently experiencing on quite a large scale, happening, in multiple countries in the world. So unfortunately, that is where we are at right now in a time that I have never seen anything like it. So it's really important that we take a look at some of these things that are recommended. Now, this is specifically looking at influenza, but it is, relevant to all airborne illnesses that can be contagious like that. So it's going to most affect those who have chronic medical conditions, who have compromised immune systems, very young, very old. That's who is usually most susceptible to complications of the flu or other respiratory sicknesses. This is transmitted by direct contact with nasal secretions and aerosolized droplets from coughing and sneezing by infected people. For diseases that can be passed through this respiratory route, we want to make sure that we are protecting ourselves as well. So making sure we have the proper PPE, so gloves, eye protection, and an N95 or HEPA respirator, and then a surgical mask on the patient if they have a suspected or confirmed respiratory disease. So surgical mask on the patient and N95 or HEPA respirator on yourself to help filter out any of those particles to help keep you as healthy as possible. Also, annual influenza immunization is important for EMS personnel. And so for those of you who will be going into the clinical phase, and we anticipated that would be, around this time. And unfortunately, we've been set back from that. But the original hope for going into clinicals now during flu season, everyone needed to have gotten that flu vaccine, and that it was to protect yourself. And that's the case for all EMS and healthcare workers moving forward. Looking at herpes simplex, this is a common virus strain carried by humans. Symptomatic infections cause vesicles that appear on the lips or genitals, and it can cause more serious illnesses in susceptible patients. The primary mode of infection is through close personal contact. So if you've ever had a cold sore, that is the herpes simplex virus, and you're carrying it. And so while there is no cure for it to completely rid your body of it, usually there is treatment that will, cause the outbreak to go away. And then again, it's lying dormant in your body until something comes along and activates it again. Looking at HIV infection, so EMTs face a risk of exposure to HIV. That's one of those bloodborne illnesses that we really want to be cautious of, and this is a big deal for us to think about. AIDS can still be fatal. However, with treatment, patients can expect a near normal lifespan. And so just again, taking into consideration that this is not our primary concern, while it is still a concern for us and the possibility of getting exposed, there are other things that we are much more likely to come into contact with, like hepatitis B. So we want to take the same precautions for everything. Something like HIV is not easily transmitted in the work setting, so your risk of infection is limited to exposure to an infected patient's blood or body fluids, and you would need to have an open wound or something like that for that blood or bodily fluid to be absorbed into, for it to actually mix. And so that's why it's such a low risk for you to come into contact with. A lot of patients will show no symptoms, especially if they've, just recently been diagnosed. We want to make sure we're wearing proper gloves to protect them and also protect ourselves. Take great care in handling and disposing of any needles that are utilized. That would be one of the only ways for you to come into contact with that infection is with a dirty needle stick. And also if you have any open wounds, to cover them prior to coming to work. If you think a patient's blood or secretions may have entered your system, you want to seek medical advice and notify your infectious disease officer. And remember, at the end of the day, we're going to follow that systems protocol as far as first and foremost transferring care over to another provider for the patient so that there's no lapsing care. Notifying your supervisor, following through with that infectious control plan, washing the areas with warm soapy water, and then you're going to get some follow-up testing for a set amount of time depending on your department's policy following any type of exposure. Hepatitis, as we said, there are several different types of hepatitis. There are A, B, and C, which are three of the most common. Hepatitis itself is inflammation and often infection of the liver, again, coming in with those three different types. Toxin-induced hepatitis is not contagious, which means if you got this from something else, like it can be spread, the infection itself can be spread to someone, but if it is coming from a toxin, then you can't spread it to another person. Now, that same person, if you're talking about like dirty needle sticks and things like that, then yes, you're sharing actual blood products and it would be contagious in that aspect. There's no sure way to tell which hepatitis patients are contagious and which are not, so we want to attempt to protect ourselves and use the same precautions that we would as with any bloodborne illness. The hepatitis B vaccine is highly recommended for EMTs. Again, this is a lot more prevalent. They have recently come out with treatments for hepatitis C, which is something that's been developed over the last few years. Currently, there is no cure for hepatitis B, but the vaccines do help prevent. Looking at meningitis, this is inflammation of the meningeal coverings of the brain and the spinal cord. Most forms of meningitis are not contagious. Now, you do have bacterial and viral meningitis. So to prevent these, we want to make sure we're taking standard precautions. This needs to be treated in an emergency department or hospital with antibiotics. Usually when we're looking at meningitis, we're thinking about the presence of high fevers, probably stiff neck pain with range of motion, especially chin to chest. A spinal tap is really the best way to confirm the presence of meningitis. If you find out that you have had a positive exposure, then you would contact your employer health representative to find out, do you need to be tested? Because again, some are contagious and some are not. So do you need to be tested? Do we need any follow-up for you as an employee?